Okay. Okay. Yeah. Good morning, everyone. At the outset, thank you, Doctor, for those kind words. Thank you, Dr. Muthupradipa, for this wonderful opportunity. And I'm really honored to be the opening batsman in this lecture series. Regards to all the teachers present here, senior teachers present here and who are online. So today's topic is on calcium homeostasis. Why calcium homeostasis? Because let us be practical, it is an important postgraduate LAQ long answer. Lot of scope for viva questions, lot of scope for recent advances, right? But beyond all that, I feel it is one mineral which by its beautiful regulatory mechanism is able to perform so many functions, staying within the normal range, narrow normal range. So that's what today's class is about. So the objectives will be the metabolism of calcium and phosphate, the physiological effects of both the hormones, role of parathermone, vitamin D, calcitonin, and a little bit on this new fibroblast growth factor 23. And finally, the integrated hormone response to maintain both calcium as well as phosphate metabolism, and few slides on the applied aspects. So by now, all of you are aware of these physiological effects of calcium, be it its physical storage form in bones or teeth, or maybe the membrane excitability by influencing the entry of sodium ions, or the role it plays in hemostasis, or as a secondary messenger, an important regulatory role in metabolic as well as signaling pathway. Now, though the topic is calcium homeostasis, I am going to speak on phosphate because you will see as the lecture proceeds, the calcium and phosphate metabolism are closely related to each other. And both of them being an important constituent of bone and teeth structurally. Apart from that, they also have this feature that they are regulated by the same hormones, more or less on the action of the same different, same organs, kidney, bone, and intestine. Though the effect of the regulatory hormones on these organs might be slightly opposing each other, but they do play an important role. And the physiological effects of phosphate, I mean, you cannot undermine it because you know ATP, which maintains life, so that requires phosphate. Apart from that, 85% of phosphate is there in the bone and teeth. It forms the backbone of nucleic acid, be it DNA, RNA, and the innumerable phosphorylation, dephosphorylation happening in all our enzymes, be it hormonal or neurobiological reasons. So with this, we move on to see this calcium and phosphate balance. How is it able to manage this narrow range of 8.5 to 10.2 milligram in case of calcium, or if it is phosphate between 3 to 4.5 milligram per deciliter. So we talked about three organs, the GI tract, the bone, and the kidney, which are going to be involved. And as far as calcium is concerned, so this is what I'm talking about. This 8.5 to 10.2 is the total serum calcium which we measure. But then you should realize that lot depends on the type which is available. In other words, you will see that 50% of this calcium, total serum calcium, is in an ionized free form. It is this form which is responsible for all the physiological activities. Then almost 45% is protein bound, be it albumin, majority is albumin, and you also have some attached to globulin. This again plays an important role in certain clinical scenarios. And finally, you have the non-ionized complex form where you have ionic bondage either with citrate, phosphate. And when compared to phosphate level, it's roughly around 3 to 4.5. Here you can see almost 84% is in an ionized form, or which is available for all the physiological actions. So again, before going into that, when I'm talking about the calcium and phosphate balance, the plasma protein level and the pH play a very important role here. For example, at higher pH, what happens is more plasma proteins are ionized. So more calcium bondage to the plasma protein. So my ionized free calcium level becomes less. Calcium to phosphate ratio in bone is roughly around 1.7:1. And another key factor which you need to notice is the solubility product. That is the product between the serum calcium and phosphate. And if it exceeds more than 60, then what happens is there is metastatic calcification of all the tissues with these crystals, right? I would like to tell here this picture, this icon on the left hand border. If this is there, then that shows that it is of recent advance or is it of clinical importance, right? Moving on to the calcium metabolism very briefly, we know that the total body calcium is kept constant at 1 kilo, when 99% is present in the bones. The remaining 1% is distributed between inside the cell, intracellular, you have intravascular and the interstitial. So that is this 1%. And in this 1% is what we are talking about, the ECF range, which is managed between 8 to 10.2 grams, right? So whatever be the intake of calcium, if it is a calcium rich food, the bioavailability of calcium is only 30%. And what happens is only 35% of whatever you have from the dietary source. Say, for example, 1000 mg per day you're taking, it is that 35% which gets absorbed, right? And the cells, like I told you, it maintains another huge bulk of calcium inside the cell, which we will be seeing in the next slide. And then we have the bone, which again we'll see about the part which is easily available, buffer available, and the next is the storage form there, right? And then when coming to the kidney, almost 90% of the filtered calcium is absorbed from the PCT, loop of Henle, and the early distal tube. But what is important to us in this lecture is the remaining 10%, which gets reabsorbed in the distal tubule and the early collecting tubule, because this is where our hormone PTH is going to act and bring about the change, right? So now I was talking about the 99% which is present in the bone. So that again, I can divide it into two, where I have an exchangeable calcium level, which can be immediately released from the bone so that it is available to buffer whenever there is a low or high of calcium. Then the major component is, of course, the slowly exchangeable calcium, that is almost the 99% or the 1 kilo, which is present there in the bone. And this picture I have put to show the importance of the other places where calcium plays an important role in our body, be it the innumerable receptors there on the surface, whether it is voltage gated or it is a store operated channel or it is a receptor operated channel. We know, as for example, in the cardiac muscle, right, we have all these different types of calcium receptors there. And of course, inside the cell, we have a huge storage, that is your sarcoplasmic reticulum, right? Apart from the various channels which are present in the mitochondria, playing an important role in the various reactions, right? So a bit on the phosphate metabolism. Compared to calcium metabolism, the phosphate metabolism regulation is not so, strictly regulated. It is little easy because the intestinal absorption is again easy. Remember, the calcium and phosphate absorption happens in the small intestine and more in the duodenum, then jejunum, and then the ileum, right? So you have almost 85% of the bones have got phosphate, less than 1% again in the ECF. What is important here is in the kidney, the two sodium dependent co-transporters in the proximal convoluted tubule. That is where we are going to see how the PTH is going to act, right? So now I have two case scenarios. We will go about the different hormones with trying to understand the case scenarios, right? So you have a 45-year-old woman who reports with complaints of muscle cramps, fatigue, tingling sensation in her fingers. So I've given the normal range. So you can see that the serum calcium level is low. Other thing is PTH level is high and vitamin D is more towards the lower side. I have one more case scenario where an 18-year-old girl presents with onset of palpitation, tingling sensation and toes, but history is suggestive of a panic attack before her exams. Here again, you can see that the serum calcium level is low. But then what is the added thing here I have given is the pH is 7.55. So this is in relation to what I was mentioning in the previous slide. The level of plasma protein and the pH is very important when it compares to regulating the serum normal calcium level. So this I can leave it as homework for you to figure out what exactly is happening, or if we have time at the end, we can discuss this further. So the entire series, I've divided it into two main chunks. That is, one is dealing with hypocalcemia and the second one is dealing with hypercalcemia. So this table shows the two important calciferous hormones, be it the PTH, that is your parathermone, and your vitamin D, right? And calcitonin is mentioned here, but since this table is about hypocalcemia, remember calcitonin has no role here. And we say three important organs as far as calcium metabolism is concerned. So you have the bone changes happening in the bone, kidney, and the intestine. So by end of the lecture, I am sure that you will be able to fill this table by yourself. So this is the integrated hormone response whenever there is a situation where the calcium level is high, that is hypercalcemia. So here you can see all the three hormones come into play, be it PTH, vitamin D, and calcitonin, right? So with this background, we move on to the hormones in section. So the first is about the parathermone. So all of us know about the 4 parathyroid glands, which is located behind the upper and lower lobes of thyroid gland. And the cell which is going to secrete this parathermone is the chief cell or the principal cell. So the main thing, if parathermone PTH is mentioned, the first point that strikes your mind is it protects against hypocalcemia, right? So how is it the cells are able to respond and secrete PTH? It is because of a beautiful receptor which is present there on the surface of this chief cell or the principal cell. That is what is known as this calcium sensing receptor, CASR, right? So here you can see the importance of the level of calcium with that of PTH. The drop may be in only millimoles, but then you can see the exponential release of parathermone here, right? So parathermone is going to be released when my free calcium is going to drop, right? So this is about the parathermone synthesis. So it comes as an 84 residue amino acid with 2 terminal, the N and the C. N is the most active part, while the C is the lesser active part of that hormone. Now in this, the left hand figure, if you can see, the calcium is sitting on this calcium sensitive receptor, which is there on the membrane of the principal or the chief cell. If there is enough calcium for this receptor is very sensitive, then what is happening during the downward signaling pathway is there is suppression of the PTH gene. If there is calcium, and if that is going to be like calcium sensitive receptor is going to sense that, then the function, normal function is to suppress the PTH gene. So you can see that very clearly. And one more hormone is your 125 vitamin D, which again has got a negative suppression on the PTH gene, right? But now we go to a scenario, you can see here the next diagram, where the calcium has come and sat in the calcium sensing receptor, which is present on the membrane. So I have my G protein, which is getting a receptor, which is getting stimulated through phospholipase C, formation of protein kinase C. What is happening here is calcium is released from the endoplasmic reticulum, right? So I have the second messenger as both the, PKC that is coming from PLC as well as IP3. And what are they doing? They're causing the release of calcium from the endoplasmic reticulum. Here is the beauty. The calcium which is released is going to suppress the secretion of PTH. Because see here, normally in physiology, if you consider most of the places, like for example, your neuromuscular junction, what is happening? Calcium is released, that leads to exocytosis. In most of the hormones, the pathway is like that. But there are only 2 places physiologically when the release of calcium is going to suppress the release of another hormone, right? Both the things, either the release of the form, also it is not letting the new PTH also be formed, right? So that can be a homework for you, trying to find out where is the other place where the calcium is released, but it inhibits the secretion of whatever dash, right? So this is how the parathermone secretion is regulated at the principal cell. So the main function of the serum calcium is normal, then the PTH secretion is not there. The PTH gene is repressed or suppressed, right? So now the parathermone has got secreted, it has to act on the receptors. As of now, 3 receptors have been identified, but we are concerned with PTHR1, right? So that is the receptor which binds both parathermone, and I'm using a new term here, that is PTH related peptide, right? So these receptors which are responsible, that is PTHR1, are expressed in osteoblast and osteocytes in the bone, and in the kidney, proximal and distal tubules of the kidney. right? So be careful here. I'm telling you that the receptors are present only in the bone and kidney. That means the direct action of parathermone is going to be in the bone and kidney, right? So now coming to the other parathermone related peptide, it is found, the receptors PTHR1 which responds to that are found in all developing organs. And these receptors are G protein receptors using cyclic AMP as the second messenger, right? So little bit on this PTHRP, because that is again a short notes for you in recent advance. The structure is almost similar to that of the parathermone hormone, but only thing is it is an 84 amino acid sequence, but this is 141 amino acid sequence. But both of them act on the same receptor, that is PTHR1, and through cyclic AMP, protein kinase C, or through PLC, I have the protein kinase C, which gets activated. Now, what is the difference then between PTH and PTHRP? PTH acts like I told you, the receptors are there in the bone and kidney. So they are going to raise my calcium levels. But PTHRP, that is this parathermone related peptide, acts only in paracrine phase, not as an endocrine. So that means it's going to get secreted and act on the neighboring cells. So it is found in the growth plate, in the breast tissue, in the teeth, and certain pancreas and certain organs when it is malignant. So coming to the clinical significance, why is this PTHRP important is, you have a situation known as hypercalcemia of malignancy. In certain malignancies like breast, skin, or lung, you have this increased secretion of this parathermone related peptide. And since this can also act on the same receptor as parathermone, that is PTRHR1, it stimulates the secretion, resorption of bone, leading to increased calcium. So this is what causes this hypercalcemia of malignancy, right? The second important thing is, and 34 amino acid analog of this parathermone related peptide is used in the treatment of postmenopausal osteoporosis. We will see the relation later. And this PTHRP has been found to play an important role in tooth eruption, right? So dental people use a lot of that for therapeutic application. And the role PTHRP plays during lactation is again significant. It helps in the removal of calcium from the mother through the breast milk to the fetus. So again, there the PTHRP is playing an important role. Now moving to the action of, we said then parathermone receptors are present on two organs. One is the bone, the other one is the kidney. Now going to the action on the bone. So just few basic things. So all of us are aware about the cortical and the trabecular wave. Cortical is the compact, almost 80%, while the spongy is the 20%, where normal hematopoiesis is going to happen, right? So the cortical bone or trabecular, you know that it somebody has to. You just somebody, the listeners, please unmute yourself. Yeah.
You can talk here.
Someone in the name of Chitra Subramaniam, please can you mute yourself? It's okay.
Yes, thank you.
Otherwise, you can just quickly unmute and tell them to mute.
So coming back to the bone, structure of the bone. So you have the organic matrix, which is made up of collagen fibers. It is mainly type 1 along with the proteoglycans. And these are the ones which are going to give the tensile strength. While the bone salt, that is your hydroxyapatite, which is present, there is the one which is going to give the compressional strength, right? So we have 99% of calcium in our body in the bones and 85% of phosphate again in the bones. Now, remember what we are going to discuss here is not about calcification, but remodeling of the bone, because that is where the topic today sits, where, the parathermone hormone and vitamin D is going to act. So just a brief mention on the three important types of cells. which have to function in an integrative way so that the calcium homeostasis is maintained. So osteoblast, that is the one which is going to cause the secretion of collagen and the ground substance, almost helping in the bone formation. So that is going to be the target cell for PTH. Then I have the osteocytes, which again are the same lineage as osteoblast. It is the end differentiation form from osteoblast, but they are the one which are going to get entrapped in the osteoid and they remain quiescent. But then when activated, remember, they help in the formation as well as in bone resorption, depending upon the cytokines and the growth factors which they are going to release, right? So this osteoblast and osteocyte are from the fibroblast lineage. Then I have the osteoclast, which is going to promote bone resorption. Now they are from the monocyte macrophage system lineage, right? So I have, remember, PTH receptors on the osteoblast and on the osteocytes. Osteoclast do not have parathermone receptors, though they are going to help in the bone resorption. So we mentioned earlier in the bone, I have two types of calcium. One is the exchangeable one, which is going to immediately buffer my serum calcium level, and the slowly exchangeable calcium, which is there in majority in the bone. Now we will see how they are utilized. So coming to this remodeling, again going back to these three types of cell, this is a picture from boron and it beautifully explains everything actually in one pic. So we said that there are three types of cells. We have the osteoblast, we have the osteocyte, which is in green, and then we have the osteoclast. So whenever bone remodeling is happening, we said that the parathermone receptors are present in osteoblast and osteocyte. So when the parathermone receptor is activated in osteoblast, two important things are released. One is your macrophage colony stimulating factor. The other one is your interleukin 6. Now these two are going to act on my osteoclast precursor cell and lead to the activation and formation of a mature osteoclast. So again, just a quick this thing, osteoblast is going to secrete my monocyte or macrophage colony stimulating factor and my interleukin 6. Now they are going to convert my osteoclast precursor into a more activated form, which is a pre-osteoclast. Now what happens here is, on the surface of this osteoclast, I have something what is known as rank receptor. Once this rank receptor arrives in the pre-osteoclast, it converts itself into a multinucleated mature osteoclast, right? So we have learned something on the surface which is rank now, right? Meanwhile, what is happening, these osteocytes, they release two substances. One is a ligand, so that can be called rank ligand because I already have a rank receptor on my osteoclast, right? So I have a rank ligand and I have something known as OPG. Now this OPG and rank ligand are the important parts to find out whether bone resorption is going to happen or bone formation is going to happen, right? So we have introduced three new terms. Remember, osteoblast and osteocytes have PTH receptors, and with the secretion of these two factors, my osteoclast is going to get matured and form a multinucleated cell which is going to resorb the bone. So on the surface of osteoclast, I have my rank, which is a receptor. But two things are released from the osteoblast, that is the OPG and my rank ligand. Right? So what I have mentioned earlier is all there in the slide. So what is this rank? It is receptor activator for nuclear factor kappa, and L is the ligand which has to go and stick on to the rank receptor. Then I have the OPG I said, which is osteoprotegrate. Now the ratio between rank L and OPG is the one which defines whether bone resolution is going to happen or not. If my rank L is going to be more than OPG, that means my osteoclast is going to become more active and result in bone resolution. But at the same time, if my OPG is more than rank L, then it means that bone resolution is going to be less, formation is going to be more. So why do I have to remember or know about all these things? Because now I have humanized monoclonal antibodies against this rank L. So when I have antibodies against this rank L, that means it is not going to bind to rank receptors, and there is no resolution of bone which is going to happen. So that is why it has made its way into treatment of osteoporosis, right? So this is again the same thing. You can see that when rank receptor has binded to the ligand rank L, that this is going to get activated, that is a plus sign. But if my OPG is bound to rank L, so that rank L is not able to bind to rank K, then you can see that negative, where bone resolution is not going to happen. Right? So now, okay, all these receptors have come and the matured multinucleated osteoclast has come. How does it resolve the bone and release calcium and phosphate? You have integrins in the osteoclast membrane, which is going to form a sealing zone with what is known as vitrodectin, which is layer present on the bone, right? And these are known as the ruffled branches. And the bone resolution happens because of one, lysosomal enzymes which are released, and the second one is your hydrochloric acid. There is in fact a proton pump in these ruffled branches which is going to have a release hydrogen, and then I have again chlorine channel with along with bicarbonate antipode way. So this HCl and this lysosomal enzyme is the one which is going to resolve these bone and release my excess calcium and phosphate. Right? So this is where the parathermo hormone comes into play. So we said first the important organ where PTH acts is on the bone. And what does it do? Act on the bone? It causes bone resolution so that more calcium and phosphate are released into circulation. So this is the cellular mechanism by which the bone is resolved. Right? So now with the effect of PTH on bones, now of late it has been shown that it has two biphasic effects. In other words, if there is a persistent increase in PTH, then the effect on the bone is different than when I'm going to give PTH in low intermittent doses, right? So what is happening if there is a persistent, like somebody has got, hypocalcemia for a long time. So he has a continuously long sustained release of PTH, or it can be a parathyroid adenoma, where the patient has got sustained release of PTH. Then what is going to happen to the bones? Whenever there is a persistent increase of PTH, then what all we discussed now, right? Be it, more rank L when compared to that of OPG, rank and rank L getting interacting, release of this HCl and lysozyme. So bone resolution is going to happen, and I'm going to get release of calcium and phosphate into the circulation. So this activation of PTH can occur in two stages. One is immediate activation of osteoclast, which has already formed, and the other one, it also helps with the formation of new osteoclast, right? So this is the scenario when I have persistent release of PTH, like for example, with an adenoma in the parathyroid, right, where the bone is going to get resolved. Now, the effect, I said it's biphasic. So now, what if I give intermittent low doses of PTH now and then? Right? This discovery was very important because this has helped in using PTH and PTH-RP as a treatment source for osteoporosis. Because I remember like 2 years back when my aunt had 76-year-old lady had a osteoporotic lesion, and she was advised parathermon injection. I still remember having that doubt, why is parathermon being given when the patient is already an osteoporotic, right? So now the explanation to that is how the parathermon is given. If it is given in a persistent higher doses, then the result is catabolic. But if it is given in low intermittent doses, then it is going to perform as an anabolic. Now, how does the same PTH act in an anabolic way? So the first thing is what is happening there is this osteocytic osteolysis. So we all know that there is a membrane in all the layers, that is it connecting between the osteocyte or be it an osteoblast. Right now, there are calcium pumps on this membrane, and these calcium pumps get activated, and the calcium which is there in the bone fluid is now thrown into the ECF. Now, that calcium and that phosphate is used for mineralization. So that is one mechanism by which this anabolic thing is happening, even when PTH is being given in low intermittent doses. The second is the release of various cytokines and growth factors. And third, you can see is the osteoblast producing OPG. Right? If you remember, when we were talking about the resolution, it was rank L which was more. right? But here now it is in an anabolic way, so the rank L is reduced, but it is the ratio of OPG which is going to be more. And we know that if OPG is more, then the bone, it is more in favor of bone formation and not resolution. And the fourth important step is it decreased production of what is known as SOST, that is sclerostin. If you can see this, a simple representation of a more complex part. So these blue things are the osteoblast getting differentiated so that I have new bone formation, while the orange ones are the osteocytes which are getting stimulated for bone resolution. Now, normally I have my WNT pathway, which is going to help in osteoblast differentiation and result in increased bone formation. But then I always have the sclerostin, that is SOST, which is released from the osteoclast and has got an inhibitory effect on this WNT pathway. So something is inhibiting the WNT pathway. So there is no increased bone formation, but I have the bone resorption happening here, right? So why do you have to know this? I mean, in spite of all the cellular mechanism is, now we have again monoclonal antibodies which are acting against sclerostin. So if I have an antibody against sclerostin, that means sclerostin level is going to decrease. So my WNT pathway can be activated and can work in differentiating the osteoblast and helping in the bone formation, right? So that is the important thing here. The drug is romosozumab. I couldn't pronounce it after even practicing it for many times. So it is a humanized monoclonal antibody, which is again SOST. So SOST is decreased. So the pathway which is helping in bone formation is activated. That is the WNT pathway, right? So again, what are the clinical significance? PTH 1234 number is now available as a pharmacological agent for the treatment of osteoporosis. Injections are given once or twice daily. Then I told you there is a monoclonal antibody against SOST. So these two form the basis for osteoporotic treatment. Now, the first organ we said is important, which had PTH receptor, was the bone. The second organ which has got directly PTH receptor is your kidney. So you remember it has three functions. The first, see, it is, we said PTH is going to be secreted whenever we have an hypocalcemic situation. So that means I require more calcium in the body. So automatically the renal pathway should be such that I have resources where more calcium is getting reabsorbed, right? So this calcium reabsorption happens in the thick ascending loop, that is Henle's loop, and the distal tube, where PTH receptors are present. And another important function of this in the kidney by the PTH is activation or increase in this 1-alpha hydroxylase. Now, this 1-alpha hydroxylase is the most important limiting enzyme which helps in converting 25-hydroxy vitamin D to the most active 1,25-hydroxy vitamin D. So here comes the indirect role of PTH. By increasing this enzyme, it is helping in the formation of 1,25-hydroxy vitamin D, which is going to increase my calcium and phosphate absorption. The third important function of this PTH on the kidney is inhibiting the phosphate reabsorption. Right, in the proximal tubule, it inhibits this sodium phosphate transporter, that is NPT2A. So this is actually understandable because we have a situation when the calcium level is less. So my PTH is raised. Now that PTH is trying to improve my calcium situation in the body. Now, if so, calcium from the intestine it is increasing, from the bone it is increasing, from the kidney it is increasing. But if you see the action on the phosphate is opposite. It is causing the more release of phosphate. If this had not happened, if there was increase in phosphate secretion, what will happen is this calcium will go and bind to phosphate. We have seen that 9% of, one part, non-diffusible, non-ionic part of calcium. So calcium, more calcium binding to phosphate, then again I am left with a situation where it is going to be hypocalcemic. Right? So it is to prevent that. You can remember that the third action is phosphate. It increases the secretion of phosphate from the kidney. Right? Now on the intestine, please remember PTH does not have a direct effect. So if it has to have a direct effect, that means the receptors have to be present. So only two organs where the receptors are present is in the kidney and in the bone. Bone also, remember, it is the osteoblast and the osteocyte which has got PTH receptors. right? So how does it cause an indirect effect is, we have seen the second function in the kidney is to increase 1-alpha hydroxylase. So whenever 1-alpha hydroxylase is increased, then I have more vitamin D active form. So that is going to help in increasing absorption of calcium and phosphate in the intestine, right? So that is why we say the PTH effect on the intestine is the indirect one, right? So this 1-alpha hydroxylase is very important because it is a limiting enzyme in the synthesis of vitamin D, which we will be seeing later. So that is increased by PTH or when I have hypophosphatemia, and it is inhibited when the calcium level is more, or the vitamin D active form is 4, or when this FGF, which is this fibroblast growth factor, which we will see what it is in a couple of slides 23. So these are the inhibiting factors, and these factors increase the renal 1-alpha hydroxylase. Now moving on to, with this we finish parathermon. So parathermon, the important thing is take home message is hypocalcemia, then the receptors present on the bone and the kidney and in the intestine having an indirect effect, right? So we move on to vitamin D, the most talked about prohormone nowadays. Everybody's vitamin D is low nowadays. So now we will see how it is helping in the calcium metabolism. So this you have either vitamin D3 or D2. So D3 is mostly formed in the skin by the opening of the 7-dehydrocholesterol by the action of sunlight, especially the UVB rays, right? So UVB rays acting on 7-dehydrocholesterol helps in the formation of vitamin D3. But then vitamin D3 and D2. D3 is called cholecalciferol and D2 is called ergocalciferol. Ergocalciferol is the one, D3, which you get from the plants, right? So D3 and D2 together is what is known as vitamin D, right? So either it is formed in the skin, or you're taking it in diet, or you're taking it in the form of supplements, right? So then being a fat soluble vitamin, it is carried through the lymphatics as in chylomicron, then reaches the portal circulation. If it is absorbed, right, and it reaches the liver, there the first hydroxylation happens to vitamin D. So this vitamin D can be either D3 or D2, right? So there 25 hydroxylase helps in the formation of 25 hydroxy vitamin D, right? Now this again bind in the blood, it is bound to this vitamin D binding protein and reaches the kidney. In the kidney, the final action takes place, that is the role of 1-alpha hydroxylase, whose concentration we have increased by stimulating the PTH, right? So this helps in the final form of this 125 dihydroxy vitamin, which is the most active form, right? But remember, there are always other enzymes which are going to convert this into the less active forms, which gets excreted, right? So for me, I'm bothered with this 125 dihydroxy vitamin D, which is the most active form, right? This I put because it is better to remember these names correctly. Vitamin D is a prohormone. D3 is cholecalciferol, mostly formed in the skin. D2 is ergocalciferol, which you get from plants. And this D2 and D3 in the liver, first hydroxylation is 25 hydroxy vitamin D. So this confusion always comes, when somebody is asking you what blood test to do, because so many vitamin D3s are there. So ideally, most of the time, what is done is this 25 hydroxy vitamin D, because it has got a longer half-life and it is not regulated. It is not a rate limiting. In other words, how much source of D2 and D3 I am giving, that much hydroxylation happens in the liver, right? Because of that, that is the one which is measured most of the time. Then you have 125 dihydroxy vitamin D, which is the calcitrol, right? So that we learned that it is in the kidney, right? This again is important because if we have a CKD patient, there is no point in giving D3, D2 or 25 hydroxy vitamin D, because as kidney, there is no 1-alpha hydroxylase for the final reaction, right? So for CKD patient, the medicine which is given is calcitrol, so that there is no reaction to happen there, right? So now vitamin D, which is got formed, it has to act on its receptor. On the plasma, it is carried through DBP, that is your vitamin D binding protein. So it acts on the nucleus. The receptor is there. So this calcitrol binds to this vitamin D receptor, which undergoes heterodimerization with retinoid X receptor. This is very essential. So this heterodimerization of vitamin D receptor with RXR brings about, along with a lot of co-activators and co-repressors, causes this hormone responsive element to get activated in the DNA. The respective target genes are, had, and that leads on to transcription and formation of new proteins, whatever be the action of vitamin D in the target tissue, right? So remember, the receptor is in the nucleus. Now, vitamin D, the main role is in the intestine, right? So we said, acting on the nucleus hormone response element, it is helping in the formation of the target proteins wherever in the target organs. So now when I say intestine, here you can see this 125D hydroxy vitamin D, which is found in the kidney and which is the most active form, has entered the nucleus of an intestinal cell, and it has caused protein synthesis. Three important things happening here. First one is this formation of this receptor, channel rather, which is TRPV6 and TRPV5, which is going to let the intestinal lumen calcium to move inside the cell, right? So first is the protein synthesis which is happening is these channels on the apical membrane. Second, it is formation of this protein bonding substance known as calbindin. So as soon as the calcium enters the cell, it binds to this calbindin so that the gradient is established. So more and more calcium can move from the lumen into the intestinal cell. Then the third important thing this vitamin D does is, on the basolateral membrane, two important channels. One is this calcium ATPase pump, and another one is the sodium calcium. It is an antipode happening in a counter transport way, right? So these are the three ways in which the vitamin D functions in the intestine to increase your calcium absorption, right? The similar way to phosphate absorption also, but which is relatively easy when compared to that of calcium, right? So these are the three things which you need to remember when I say how 125 dihydroxy vitamin D functions in the intestine. So this will lead to increased calcium absorption. The second important function is in the kidney, right? In the kidney, it works synergistically with parathermone. That means it is going to increase the reabsorption of calcium, right? But again, it promotes phosphate reabsorption. Remember, PTH, it was the opposite action. PTH, it led the phosphate to urea, but here it helps in the reabsorption of phosphate. And the third important thing is it inhibits the 1-hydroxylation of vitamin D, right? So you have one action of parathermone, which it works synergistically. The other two action are opposite to that of what PTH did in the kidney, right? So now coming to the bones, the role of vitamin D in bones. So it has got two effects here again. Indirectly, it helps in mineralization because it has helped in increased absorption of calcium and phosphate from the intestine and from the kidney. So I have more calcium and phosphate, so it can help in the bone mineralization, right? But then vitamin D in excess has the opposite effect. It increases the bone mobilization or resolution, right? So better to be aware of this before telling anyone to take 60K every day or something like that. So now moving to the the poorer sister, I say, when compared to parathermone and the other vitamin D, the calcitonin, but it plays its sweet role there. Peptide hormone produced by the medullary cells or the C cells of the thyroid gland. So it is positively regulated by the serum calcium level, right? And there again, you have this calcium sensing receptor. So what it does here is it inhibits the bone resorption, that is opposite to that of PTH. Calcitonin is released whenever there is an increase in serum calcium. So whenever there is an increase in serum calcium, I don't want my bone to undergo resolution. So that inhibitory effect is caused by this calcitonin. Since it inhibits bone resorption, it is again found a way in the treatment of osteoporosis or Paget's disease. Right? So this picture, we have already seen the down part, where the lysozyme and the HCl has brought about the bone resolution. But if you concentrate on the upper part, here you have the calcitonin, which is coming and binding to the calcitonin receptor, which is present in the osteoclast. Here again, remember, osteoblast and osteocyte has got PTH receptors, but osteoclast has got the calcitonin receptor. Now this calcitonin, on combining with its receptor, it activates a G protein, protein kinase A, and through that mechanism, it causes inhibition of bone reabsorption, right? So this is how it is able to reduce the level of calcium. That means this hormone is getting released whenever there is an increase in the level of calcium, right? So this calcitonin, there are certain other factors which help in stimulating calcitonin. One is all beta adrenergic agonists, dopamine, estrogen, gastrin. Gastrin secretion causing a release in calcitonin is important because Zollinger-Ellison syndrome, we always observe that there is a raise in plasma concentration of calcitonin, right? And receptors, as I told you, it is there in the osteoclast and in the kidney. So its action, bone, it inhibits bone resorption, while in the kidney, it causes an increased calcium excretion. Because remember, its mechanism is only when my serum calcium is going to be more. When it is more means I need more calcium out of my body. So that is how this is acting. But actually there is no syndrome or anything named whenever there is a deficiency of calcitonin or whenever there is an excess of calcitonin. But definitely it plays a role in infants and in lactating mothers. It helps in mobilizing calcium from the mother to the feeding infant during lactation period. Now, a bit on this fibroblast growth factor 23, because the effect of this is less on calcium metabolism but more on phosphate metabolism. But with the discovery of this, in fact, bone, it has been proved that bone can function as an endocrine organ, right? Because this FGP is formed produced by the osteocyte. So what is its function? It inhibits the phosphate absorption in the kidney. That means you can remember it like PTH. PTH also causes increased phosphate secretion in the urine. This again causes the same thing. But is it of any importance? Yes, definitely. Because in autosomal dominant hypophosphatemia rickets in children, there is an excess of this FGF23. And also whenever there is an osteomalacia due to a tumor, there again this FGF is found to be more, right? So one thing to remember from this is my 125 dihydroxy vitamin D, the most active form, decreases the production of FGF23, because it is understandable, because we have seen that this is secreted when there is more phosphate. So that helps in removal of phosphate from the body through the kidney. So now moving to a scenario which is commonly seen and trying to find out how to integrate all the three hormones in bringing about this calcium homeostasis. So, which is the most common scenario now is the vitamin D deficiency. Since vitamin D3 is deficient, sorry, not D3, the active form is deficient, you can see that there is no absorption of calcium and phosphate in the intestine, because that was the principal role of vitamin D, the three functions there in the intestinal cells, right? So since there is a less absorption of calcium and phosphate, my serum calcium and phosphate is going to be less. So that will be the stimulus for my increased parathermone secretion. Now that parathermone is going to act on the bone and try to increase, through bone resolution, increase my calcium and phosphate. But the same PTH will act on the kidney and remove the phosphate. So at the end, what do I have? I have less of calcium and less of phosphate. So I have poor mineralization of the bone happening. This is what leads to the term used osteomalacia in adults or rickets in case of children, right? So try to understand this loop, how vitamin active form being less, resulting in less absorption of calcium and phosphate. So that causing a secondary raise in your parathermone secretion, but that again leading to low serum calcium, low phosphate, and finally I have a situation where poor mineralization is happening. So children use the term rickets, where the growth of long bones are impaired. The rib cage, ankles, wrists get deformed, with especially the long bones resulting in this bowing of legs, which is like the clinical sign of rickets. Then in case of adults, we use the term osteomalacia. That is when you have a poorly mineralized osteoid, right? So weakness, bone pain, and sometimes it might lead on to fractures also. Now the same integrated hormone response, two scenarios again, whenever there is a reduction in serum calcium and there is a reduction in serum phosphate. I think this you can easily frame by yourself with whatever you have seen now. reduced serum calcium, so my PTH is going to be more. Because of increased PTH, my vitamin D formation is going to be more. So then how it is able to acting on the bone, acting on the kidney, and acting on the intestine, it is able to increase my serum calcium and phosphate, right? So this was just a quick summarization of what we have read till now. Now, we cannot complete the calcium metabolism without a word on this, how important is the gonad steroidal hormones. Because we have been mentioning many a time about this postmenopausal osteoporosis and the treatment in the few segments, right? So we have the 17 beta estradiol, which promotes the survival of osteoblast, but at the same time, apoptosis of osteoclast. Because we know osteoblast is going to help in bone formation, but osteoclast is going to help in bone resolution, resorption, right? So that is how protective this estrogen are. They help in the survival of osteoblast, but at the same time, they cause apoptosis or cell death of this osteoclast. Now, androgens like testosterone also have an anabolic effect. So we always know that the males have, dual positive thing there. One is they have the testosterone. Second, in the periphery, some of the testosterone can be converted to estrogen, estradiol group, right? So from both, they have this bone formation or favoring formation beneficial effect. So, but then it is harmful, or in the sense, postmenopausal women, there is a rapid bone loss, because then we use the term postmenopausal osteoporosis, because we know that the estrogen and the progesterone level functioning from the ovary becomes less, right? So, this is about the postmenopausal osteoporosis, the reason. And we already seen the treatment plan. Either it can be an antibody against rank L, or it can be an analog of this PTHRP, or an antibody against sclerostin, so that my WNT pathway is activated and then I have bone formation happening, then resolution. The other important thing which you will see is the osteoporosis related to the continuous use of glucocorticoids. You know that steroids given in a lot of conditions where the immunosuppressant function is to perform, but then this at higher doses and given for a longer time, it promotes bone resorption, inhibits GI calcium absorption, and there is also inhibition of osteoblast differentiation. If osteoblast differentiation does not happen, then it affects the formation of the bones. And whatever calcium you eat, though if you take 1000 grams, only 30% is the bioavailability, 35% is only absorbed, right? So that is getting inhibited here, and it promotes bone resorption also. So that is why you have this glucocorticoid induced osteoporosis. So coming to now, till now what we have seen, the major reasons for this calcium level dropping, the most common and important cause is this hypoparathyroidism. This happens most of the time when there is a thyroid surgery and this parathyroid gland has been removed by mistake. So 36-48 hours post-operative, the patient comes with symptoms of hypocalcemia. Or that is because now I don't have PTH to maintain my serum calcium level. Or in a condition like this Albright hereditary osteodystrophy, here what happens is my parathyroid is secreting parathormone normally, but there is a problem with the receptor. That is the G receptor which is there. You know, in the end organs where PTH has to act, there is some problem there in the defective gene protein receptor. So I have a situation where there is resistance in the PTH, right? But the most common clinical scenario which you will, relate to is what happens in chronic cranial failure or in CKD, right? So we know in CKD, the first thing which is happening is there is a reduction in GFR, glomerular filtration rate. So whenever there is a reduction in GFR, normally my phosphate metabolism also goes for a 6. My phosphate is not, secreted properly. So what I have is, because of reduced GFR, I have increased phosphate. And we have already seen this increased phosphate can always combine with this calcium. So it decreases the availability of ionized serum calcium. So that is one thing. Second, whenever there is a CKD, you know that the formation of 1-alpha hydroxylase is going to get affected. If 1-alpha hydroxylase is not formed, then I don't have my active vitamin D being formed there. So no active vitamin D to cause intestinal and renal reabsorption of calcium and phosphate. Third, because my calcium level is less, what will happen is my parathormone will start getting secreted. So I have what is known as secondary hyperparathyroidism. So all these three things together, that is my reduced GFR with increased phosphate. Because of that, there is reduced calcium, there is decreased production of 1-alpha hydroxylase, and increased PTH, which is causing bone resolution. You end up having what is known as renal osteodystrophy, right? So now I cannot end calcium metabolism without a word on tetany, because latent tetany is a favorite question of examiners. So hypocalcemia, that is when the plasma calcium level is fallen to say 7 milligram, it leads to tetany. What is happening here is the spontaneous action potential in nerves, because the calcium is going to influence normally the sodium permeability in the nerve membrane, right? So because of that, you have increased excitability of the nerve and neuromuscular junction. So we have few signs here. Either it can present itself with carpopedal spasm, that is the trocheus sign, where the spasm of muscles of hand is there, and it can affect the feet, or even when laryngeal muscles are involved, you have the laryngeal spasm, right? So latent tetany is manifested by what is known as the Chostek sign. Tapping the facial nerve at the angle of jaw causes quick contraction of the facial muscles on that side. So I have a small video which was circulated last week in the APT group by Dr. Rao sir. I taken sir's permission in showing this video. Just
Only the video.
Audience here.
Yes, ma'am.
Yeah.
Yes, ma'am.
I have a video and post it in the alumni group.
Okay, ma'am.
But for the other people, how would they see it? Only if you share that screen, they will see
Yes,
it.
ma'am. On it, ma'am.
You people have it in your group for DPGs. Nobody responded. You can take a look at it now.
thank you. Thank you. So where you could see the latent tetany when the facial nerve was tapped at the angle of jaw, that particular side facial muscles contracting, plus the carpopedal spasm, which was also demonstrated. Right. So till now, what we had seen was hypocalcemia and the role of this PTH, vitamin D. Remember, hypocalcemia, no role of calcitonin, right? So now hypercalcemia, two scenarios. One, 50-year-old man presents with complaints of weakness, fatigue, and bone pain. Here you can see the level of serum calcium, which is definitely above the normal range. And you can see the level of PTH also being high here. Vitamin D is within the normal range. The other scenario, 40-year-old lady reports with lump in her right breast getting investigated for malignancy breast. The laboratory investigation, again you can see the serum calcium level is more, but then PTH is within the normal limit, but then you have this PTHRP, that is your parathermone related peptide, which is way above the normal range. So we have seen a situation where the PTHRP can cause hypercalcemia of malignancy. So this case file is regarding that. So the common cause is an adenoma in the parathyroid gland resulting in primary hyperparathyroidism, or the next one I mentioned, that is the hypercalcemia of pregnancy, where the parathermone related peptide is being released, especially CA of breast, lung and skin being the commonest. So the symptoms here, most of the time it is asymptomatic, but the patient can present with fatigue, muscle weakness, bone pain, constipation, altered mental status, and this hypercalciuria can present itself as renal stones here. So this is what is happening to the table if I'm going to increase the calcium level. Here, if you remember, the last thing was empty in the case of hypocalcemia, but here the calcitonin has come into role to reduce my serum calcium absorption from the bones, at the same time increase the secretion of calcium and phosphate, right? So this is again the summary of the same thing. You can remember it like this. Here there is a decreased calcium. So the first and the last column, it is not there. Calcitonin is not going to act now, right? So before completing, I thought, because these two terms we always get confused because we don't see patients so much, that is osteoporosis and osteomalacia. So the main differences I have noted it down. So definition, osteoporosis is reduction in total bone mass with loss of organic bone matrix. We have seen that salts and bone matrix are two components, be it cortical or the trabecular bone. But if it is osteomalacia, it is softening of bones due to reduced mineralization of the bone, right? Pathophysiology, osteoporosis, you can see that there is an imbalance between bone resorption and formation. That means my osteoclastic activity is going to be more. But in case of osteomalacia, we have already seen I have inadequate availability of vitamin D, right? So failure to deliver the adequate amounts of calcium and phosphate for mineralization to happen. Risk factors, osteoporosis, we have seen all this: old age, postmenopausal, prolonged immobility, and excessive use of glucocorticoids. But when it comes to osteomalacia, the dietary deficiency, lack of exposure to sun, even though we have exposure to sun, but then as Southeast Asians, our thickness of the skin is more. So the melanin going inside, melanin there with the sunlight not being so effective in formation of vitamin D3, liver disease or the kidney disease. Kidney disease, remember the treatment has to be 125 dihydroxyvitamin and not your vitamin D3 or 25 hydroxylate, right? So clinical presentation, osteoporosis, initially asymptomatic, later may present with fracture. But osteomalacia, again, in children, we use the term rickets. In adults, and or it can present itself as a dental problem, right? So these were the referred books. I've taken all the pictures from Vernon Levy and Boron, and 2-3 articles. The reference has been given in that slide itself from where I've taken that. Thank you. And these two I have left it for homework. So if you have understood, you can fill the table. One is hypercalcemia, and the second one is an hypocalcemia table, right? Thank you so much for the patient hearing. I have done justice to the topic. Yeah, yeah.